Thank you, Shama and Mindray team. I have great pleasure in introducing my ex-colleague and a close friend, Dr. Rajesh Bendre. He's a MD Path, DNB, and DPB. He's presently working as the Chief Pathologist and National Technical Head at Apollo Diagnostics, Hyderabad. He's a postgraduate from Grand Medical College, Mumbai, has technical work experience of more than 25 years in a standalone and a hospital-based and a reference labs handling clinical chemistry, hematopathology, and molecular pathology. Academic teaching experience for MBBS and MD or DNB path postgraduate students for more than 10 years. 5 international publications and participated through posters, oral presentations in many national and international conferences. His special interest in autoimmunity, flow cytometry, hormonal and drugs assays by HPLC, LCMS, and trained in management of component blood bank and apheresis services. He's accomplished NABL CAP assessor as per ISO 15189 of 2012 and ISO 15189 of 2022. Trained in laboratory management through IIM Calcutta and IIM Indore. Acquired skills in development and implementation of laboratory information system. So Dr. Rajesh is here to speak on tumor markers. Rajesh, floor is yours. Thank you.
So very good afternoon, everyone. And at the outset, I thank Mindray to providing me this opportunity to share some of the thoughts on this topic given to me, which is serum tumor markers as per current clinical practice. Now, this is a very huge topic, and I hope I would be able to do justice to this topic. So starting right away, so taking some introductory and setting some background to what I want to present. So when we talk about serum tumor markers or biomarkers, what are they? So they are basically substances which either the tumors produce or they could be various host reaction and proteins of the host reactions that we are looking at. In either which ways, we want to get some biological characteristics of the tumor using these biological markers. We may measure them either quantitatively or we measure them qualitatively. In terms of our understanding as to what is the nature of these substances, they could be antigens which are secreted by the tumor and released into the periphery. They could be hormones secreted by the tumor cells. They could be enzymes, or they could be tissue-specific proteins. And in today's era, which is the last part by which I would like to conclude, is the nuclear proteins, which is the next future that we would be talking about as various signature molecular proteins and liquid biopsy. And that is where I would like to end. In either which ways, whatever are the characteristics of this particular substance, we would like it to be as an ideal biomarker with reference to that particular tumor. So does an ideal tumor marker exist in today's world? And what is it that we would like to have when we use the word as an ideal tumor marker? So we would like this tumor marker to be highly specific. So when we say high specificity, we would like to have in terms of numbers, it should have a specificity to as high as 95%. It should be highly sensitive. So that means it should be at least 90% sensitive. It should have a very established medical clinical decision-making cutoff. And that cutoff which a clinician can use either to differentiate between a normal or a healthy versus a abnormal or that is a cancer patient. And the same marker he would also like to use later on as a follow-up or during monitoring. And last but not the least, which is purely our domain as laboratorians, that we would like to have the methodologies for these various markers, and all those methodologies we would like to have it very nicely standardized and harmonized. So that is what we would define, or we would wish to have something like an ideal tumor marker. So do we have one, and are we there? Let's discuss on that very, very quickly. So there is a whole gamut of list of tumor markers that we know today, and they have evolved over a period of last, say, 2 decades. And that's a whole list which we all know which often always are even specific to certain cancers. In fact, there are various recommendations as to how they should be used as well. So not all of them can be used for screening, diagnosis, and monitoring. So each of them has its own utility and a purpose to be used in a clinical setting. But is it really followed as per the recommendations and guidelines? Again, a big question mark. The big example here I would like to quote, in my experience being abused or misused, is CA 15.3. CA 15.3, the recommendation is purely as a monitoring marker and for CA breast, but we often see this being used for diagnostic purposes. And here is where all the disconnect starts and a lot of queries that we need to handle, both from a patient side and from the clinician side. So that is one message, that whatever list of tumor markers that we talk about, there are standard guidelines and recommendations as to how we should be using it in terms of diagnosis or monitoring, and we need to ideally completely follow those guidelines. So having set that background, now let me run through individual tumor markers that we know today and talk about certain advantages and limitations of each of them in this short time which is given to me. So taking the first one, which is more or less a more time-tested one, which we all know, it's CA125. So serum CA125 is almost, we corroborate it with a marker for CA ovary. And yes, definitely true, we know that CA ovary, when we talk about, and if you look at the WHO classification for CA ovary, it is humongous, it is huge, it's like a Pandora's box. And out of the so many lists of tumors that is possible in ovaries, the one which is really related to CA125 is only one histological type, and that is serous surface epithelial tumors of ovary. So that means that you may have a patient with a huge ovarian mass, but the CA125 report can come perfectly normal. It just means that this patient is probably having an ovarian tumor which is of non-serous type. So that's one very important point, that when we say that CA125 is related to CA ovary, it is with the reference that serous surface epithelial tumors of the ovary are the commonest variety. And this is the marker which is raised in this particular type of tumor. Having said that, it is not, though it is something specific for this particular histological type of CA ovary, it is still not a specific marker for CA ovary. And the reason for that is, if you go back to the embryology as to what this protein is, this is a protein which comes out from mesothelium. And all the cells which are derived from, which are mesothelial derivatives, they are the ones which can secrete CA125. So when I say this, now you can go back to your histology, anatomy, and you can understand that the ovarian capsule, the peritoneum, the pleural surfaces, they all have mesothelial linings. So any conditions which irritates the mesothelial lining here will cause a rise in CA125 apart from the ovarian tumor. So that makes CA125 less specific because of this very biological nature of the protein. So if you look at the literature, that's what it comes out to be. That's what it comes out to be, that in a screening when you use, it has got about 83% of the patients can be detected for epithelial ovarian tumors, and those are the sensitivity specificities, and the number which gives you the maximum sensitivity and specificity is 65 and above. If you recollect, our reference range is more or less 35. So we are talking about 2 times the upper normal range. A number is likely to be most significant in favor of a possible ovarian tumor. A further very nice guideline which ACOG and SOGC has given up in terms of interpretation of this single number that we get as a serum CA125 is this. You should take the patient's age into consideration. If the patient is premenopausal and in the reproductive age group, any number that is about 200 is to be considered significant. But if a person is postmenopausal, any number more than 35 is to be considered significant. Very, very clearly defined by ACOG and SOGC guidelines. And the reason that they are talking like this is the same background the comments which I made earlier, that there are more possibilities of other benign conditions, infective conditions, which can also give rise to rise in CA125. Now, can we make this marker more stronger and more specific? So the answer to that is yes. we can make this more specific and more stronger in terms of identifying CA ovary, and that is if I complement it by using other biomarker. And one of the other biomarker which has been used is what is called as HE4, which is human epididymis protein 4, which is being documented to be overexpressed in majority of the ovarian tumors, especially epithelial ovarian tumors again, and that is how it is being used in conjunction as a complementary marker with CA125, and you have a software algorithm which would statistically give rise to a risk calculation in favor of malignancy and not in favor of malignancy, which is what is referred to as risk of ovarian malignancy algorithm, or ROMA. The cutoffs which are recommended, as you can see here, again we have to take into consideration whether it is premenopausal or postmenopausal, and the cutoffs as 13 or 28, as a combination of two biomarkers, CA125 and HE4. There have been another similar study also where more number of biomarkers were used in combination with CA125, and that was called as OVA1. And there are comparative studies between ROMA and OVA also available in our literature, where it has proven that ROMA seems to be a better statistical model rather than OVA1. So this is one way by which CA125 specificity can be improved by using complementary markers, especially HE4 and ROMA. Okay, so that was some points to highlight specifically on CA125. I shift to the other very commonly used marker, serum marker, which is PSA. Now PSA, again, like CA125, yes, it is an enzyme which is secreted by the prostatic epithelium and prostatic epithelium only, and thus it becomes very, very specific to prostate. The normal function hypothesized of this enzyme that it facilitates in liquefaction of semen. This particular enzyme, which is secreted by the prostatic epithelium, circulates in our serum combined with certain proteins. And that is how, like our thyroid, the concept has evolved as total PSA and free PSA. So the part of enzyme which is not protein bound is the free PSA, and that's the next slide which I am going to show of a combination of total PSA, free PSA, and we talk about a ratio between the two, which makes it more specific in identifying a possibility of a CA prostate instead of a standalone total PSA alone. As it is an enzyme, one must realize and always keep in mind that any infection in prostate, any infarction in prostate, any benign enlargement of prostate will also cause rise in this enzyme. And very, very important point, this is our pre-test limitation. Any manipulations in terms of per rectal examination or any procedures, we should not be doing the test immediately for PSA, which will give rise to erroneous or false increments in PSA. This is worthwhile to remember. If there is a biopsy which is done, the patient needs to wait for at least 6 weeks before a test of PSA should be prescribed or should be done. I don't think most of the clinicians or even our own laboratory people are aware of this particular pre-test requirement before we collect a sample for total PSA. So these are some very important points that we need to bear in mind. Another thing which I want to highlight is this table. Generically, we always say as a reference range for total PSA as 0 to 4 nanogram per ml, by and large. But if you look at the literature, as age advances, your PSA levels also increases. So especially in elderly patients, if you are doing the PSA for the first time, this is something which we must also keep in mind, the age and the total PSA level that we are looking at. Okay, as I said, we can make the specificity of this marker better by combining it by using with free PSA, and we take a cutoff of 25% as a ratio between free PSA to total PSA, and that's what the literature says, that if you have this ratio, which is less than 15%, it is the message to the clinician. When you look at this particular ratio, the grid or the recommendation, it goes like this, that it may warrant a biopsy, and the risk of possibility of a CA prostate is in the range of 28 to 56%. If the ratio is 15 to 25%, the risk is 12 to 19%. And if the risk is ratio is about 25%, that you may avoid a biopsy, just follow up by a DRE, and the risk it becomes as low as 8%. So that's what the cutoff of 25% is what is recommended as a ratio between free PSA to total PSA as a guideline to interpret the ratio. The same total PSA can also be used as a monitoring tool in a diagnosed case and after post-surgery. And here the cutoff is what I wanted to highlight. The cutoff what we must be looking at is 0.2 nanogram per ml. Sorry, is 0.2 nanogram per ml. So if you are having a patient of total PSA as a follow-up, so that is where we should be careful. If you have a number of total PSA in a follow-up patient post radical prostatectomy, if it is going 0.2, this should be our laboratory alert to the clinician that this warrants further investigation. It warrants probably a recurrence or probably a resurgence of a metastatic lesion somewhere. Okay, going further to the next serum tumor marker, which is alpha-fetoprotein. So in alpha-fetoprotein, the points which I wish to highlight, number one is the units. There are various kits available. Some kits give us in terms of IU per ml, some kits give us in terms of Ng per ml. So it would be best and a good laboratory practice that if we put the conversion factor in our report format, so even if the patient follows up from different labs A to B, the clinician is able to convert and correlate it appropriately. That is one very important point. Alpha-fetoprotein is a very important marker, especially when it comes to liver diseases and when it comes to hepatocellular carcinoma. But please remember that AFP can also rise in non-liver conditions, and mainly it is the germ cell tumors where it plays an important role as a tumor marker. In the previous lecture, Dr. Bernali was mentioning about clinical reportable ranges, and we just spoke about a point where do we have to report values beyond the AMR or beyond the dilution protocol given by our manufacturers? This is a classical example, and I will relate to that discussion which Dr. Bernali made. Now, clinician for this particular marker will definitely not agree and will make you give you the endpoint titer. And the reason for this is the last sentence, that this is a marker which correlates with the tumor burden. And that's the reason the exact number is very, very critical for the clinician to know. So this is one tumor marker where clinician will never agree, and he will always want us to give us the final number. So yes, I do agree with what Dr. Bernali advised us, that in terms of medical legality, we cannot go as beyond the kit insert or manufacturer insert, but we need to comply by what the clinical need also is. So what I would follow in my practice, which I do follow, is I would give the first report as above whatever maximum dilution. In the remark, I will say further manual dilution done as per clinician's request and give whatever the number is. So I comply by both the requirements, medico-legally, as well as the clinician's need. AFP again, and when you talk about hepatocellular carcinomas, again there is a catch. There are almost 1/3 of the hepatocellular carcinoma tumors which do not secrete AFP. So what do we have for them as serum tumor markers? So we have certain other biomarkers here, and the other biomarkers that we have are these two. Now AFP, if you look at from an electrophoretic point of view, it has got 3 subfractions, and what is considered is you take L3 fraction is the one which is especially increased in these other hepatocellular carcinomas or non-AFP secreting hepatocellular carcinomas, and a ratio between the total AFP and L3, if it is more than 10%, this is one way of identifying them. Another marker is DCP or PIVKA2, which is also called as your protein induced by vitamin K absence or an antagonist 2. So this is another novel marker. ELISA kits of research only use are available, and that can be also used in such cases which are non-AFP secreting hepatocellular carcinomas. So the next tumor marker is CEA. In CEA, one must consider that the reference ranges for patients who are smokers, patients who are having inflammatory bowel disease, chronic lung diseases, the cutoff then is considered an elevated cutoff of 10. If all these predisposing factors are not there, then a cutoff of 3 can be considered for CEA. So that's a very, very important point which should be there as a part of our report formats. CEA is a very, very important classical marker for definitely a colorectal carcinoma, both for diagnosis and also from prognostic point of view. When we talk about it in terms of post-chemotherapy in a colorectal carcinoma, the cutoff considered is 6 nanogram per ml. So I think what I'm trying to do, I'm going a bit fast, but what I tried to compile here is these cutoffs. I think as a laboratorian, we need to know these cutoffs when we are reporting our tumor markers. And as we correlate with the history from the clinicians or the patients, this is what we need to correlate and discuss with the clinician accordingly. This is what would give a value add, and that is what I suppose the clinician is also expecting. CA 19.9, now this is an extremely notorious and a tricky marker, I would say, and the reason being that the nature of this marker is that it is a mucin. And because that it is a heterologous mucin, the assays are poorly standardized. A very, very notorious assay, Vidas, Roche, Abbott, huge variability you will see in this CA 19.9. A patient who is having a rise in CA 19.9, and because it is a mucin, it also causes interferences in lot of our other immunoassays and other tests. So that is one thing which we must keep in mind. You can have abnormal peaks causing in protein electrophoresis because CA 19.9 is raised. And there are published cases on these. So these are certain issues with this particular marker. But yes, this is the only marker that we have in order to diagnose CA pancreas. And that is one of the important markers for CA pancreas for us to pick up. Okay, another very commonly used marker is beta HCG. And here I want to highlight, like CA 19.9, though it is one of our commonest marker, the molecule beta HCG circulating in our serum is extremely, extremely complex. And if you look at what all circulates as a form of beta HCG, are so many different forms. And our kit that we use, does it target all of them? I don't know. I don't have an answer. And if we really compare, I think there will be a huge variability between all our standard kits that we use in terms of what are they targeting as a molecule, as an immunoassay. And this itself causes inherent variability between our results across the lab and across the testing platforms. So very important point that one must keep in mind. And for this, obviously, scientifically, we will never have an answer to this. But what the message I think we should give as laboratorian to the clinician or to the patient is follow one lab. So that is the best way that the clinician does not get misled or the patient also does not get misled. So that is one point. And the same thing is corroborated. I have pulled out a CAP participant summary here. The same CAP sample, which is run across the world in different labs, done by Siemens is 702. The same sample done by Vitros is 1844. So this itself tells the fact that they are not standardized, and you have so much of variability from 700 to 1800 from a same CAP sample tested in a survey. So this is one point, first upfront, that I would like to highlight. Going ahead, when we report in terms of beta HCG as a tumor marker, we all know this is a tumor marker very, very important in gestational trophoblastic diseases. And this is one disease where is a single chemotherapy methotrexate which makes wonders and works wonders. But a very critical point is this, that what a clinician is looking at in a follow-up beta HCG, once a methotrexate is given, is this, a 1 log reduction within 18 days after the first treatment. This is what they are looking at, and if this is happening, means the patient is responding. If this is not happening, means either they have to step up the dosage or maybe they'll have to add certain other chemotherapeutic agent. So I think this is a key that we should be looking at when we are reporting it. Another problem that I have also faced many a times is unpredictable transient rises in beta HCG when the patients are on follow-up. And this is especially known in patients with molar pregnancy or patients with choriocarcinomas. As choriocarcinomas, as we all know, histologically has got extensive areas of necrosis and hemorrhage. So tumor necrosis as a phenomena is common in choriocarcinoma, which can give rise to this transient rise in beta HCG. And this can cause a lot of interpretative challenges and problems when in a follow-up patient. So there is published reports on transient rise in beta HCG follow-up in such cases, so wanted to highlight that point. Chromogranin A is another very important novel marker which has become a very important marker now for almost all neuroendocrine, suspected neuroendocrine tumor in the body, ranging from carcinoid to your small cell carcinoma lungs to pheochromocytomas. So for any neuroendocrine tumors, this has become a very important novel marker. So here, again the cutoffs, if I have to highlight, the reference range, what we would consider is 60. The reference range here, what we would consider is 100. But when we are talking about a neuroendocrine lesion, usually it is 2 times the upper normal range, that is about 200 is what we must be considering as significant. The reason why it is almost 2 times the upper normal range, the answer to that is this, that this marker, again, there is a pre-test prerequisite that we must be looking at. Patients who are on H2 blockers, our simple antacids which people take without even non-prescription antacids that everyone takes, that can interfere and cause false erroneous rise in chromogranin A. So patients should be off any antacids before they are giving the sample. A very, very important pre-test requirement that we must be looking at. Thyroglobulin and calcitonin, again important markers for our thyroid carcinomas, medullary and follicular carcinoma thyroids. So here what I want to highlight is about thyroglobulin. Thyroglobulin, one notorious point is some technical challenges here. And technical challenges is that there are interferences with this assay, especially if there is a concurrent presence of anti-TG antibodies. And if there is so, we should be careful about it, we should be aware about it, and accordingly report with a rider if that is positive along with the whatever value that we are getting for TG. Okay, so having run through some important specific individual tumor markers that, and some salient points on them, coming to this. Why do you want to have such huge battery of different single markers? Can I have only one universal single serum biomarker? And the answer to that also is yes. There have been a marker which came into existence as FDP-DR70, and this was extensively studied, especially in stomach and colorectal carcinomas, and it showed very, very promising results. And then it was also extrapolated for all other cancers, where you can see there is some variable sensitivity and specificity, the way it behaved. So finally, FDA gave approval to this particular marker as a universal cancer marker, but FDA gave it as an approval for monitoring purposes only, and that too for CA colon only. So this is what was the story was of this marker, but people misused it, and there were a lot of litigation cases, and currently this marker again is withdrawn by the company because of the litigation cases. And the reason is not because scientifically this marker is wrong. The reason is it has been misused for diagnosis and screening purposes, which it was not supposed to be done. It was supposed to be done only for monitoring and in cases of CA colon, but unfortunately it was used for something else. Since it is a FDP, one should also take into consideration other causes, other non-malignant causes, which can give rise to rise in FDP before we interpret this particular marker. So that also is a limitation with this particular marker. So what is the next new future? So the current stage as what we are, and as the world is moving towards molecular diagnostics today. And that has already happened in the field of oncology. And we are already talking about various signature markers and a liquid biopsy using a peripheral blood sample. So when I talk about serum tumor markers, apart from our clinical immunoassays and biochemistry, we are moving from this to molecular genetics and cancer genetics using a peripheral blood sample. So the example for this and why it is happening is because NGS as a technology, which was always available only in research labs, today it is no longer a research lab technology. It is easily available in most of the reference labs today. And now that it is easily available, the sensitivity of these NGS has also improved significantly in the past decades. The challenge when I talk about using molecular markers in oncology is a very small amount of DNA, which is what is circulating in the peripheral blood, like a needle in a haystack, is what I want to pick up and I want to identify. So the current NGS technologies have improved so much that they have this capability of identifying very, very small and very, very low quantity of abnormal DNAs within a peripheral blood sample. And hence, that central dogma, which we all learn as DNA gives rise to messenger RNA gives rise to protein. So our whole focus right now was here, the final protein. We were targeting this. So now we are taking a deeper dive inside, and we are now looking at messenger RNA and DNA to give the same information. So some of the examples which you already know. Classical example is chronic myeloid leukemia. BCR-ABL transcripts and real-time PCR for both diagnosis as well as follow-up of a CML patient is already existing today, right? So your RT-PCR transcripts, which we identify on an RT-PCR in a peripheral blood for CML, is nothing else but a molecular biomarker which is present in a peripheral blood. Same way we have HER2 for CA breast, EGFR, BRAF, ALK, and ROS, which is already available, and we are using it for CA breast and lung cancer.
Dr. Rajesh, you have only 1 minute left.
Yes, last slide. So this is what is already existing. These markers, as we are identifying, we are having targeted therapy, and this has evolved to personalized medicines and theranostic, and this is going to evolve still further. What is still the future which beholds us? The still future which beholds us is this part, which again maybe in another 5 years down the line will happen. A general screening marker for cancer genomics for general population, having known this entire knowledge that we would have of this cancer genomics and genetics. So today we are talking about targeting hotspots, cancer hotspots alone. Now we are talking about screening the entire DNA of a person and predicting a possibility of a cancer in near future. So that would be the next step. And there the key role would be played by this analysis, which is methylated DNA markers, which is going to be the next future. So those were my thoughts on serum tumor markers. Thank you for a patient listening.
Thank you, Dr. Rajesh, for a nice presentation of tumor markers. Anyhow, future of cancer testing will be NGS. Let us have 1 or 2 questions from the floor. Any questions? If
Any
there are
questions?
I hope there are no questions, I think. Everything is clear, I think. Thank you. Thank you.
Thank you.
May I request Dr. Ramesh to please hand over the certificate to... May I request Anil to hand over the certificate to Dr. Ramesh Kumar? So I think we will have running tea coffee, so that we won't waste more